Hi, my name is Jack Crow. I'm an aortic dissection survivor, and I am an aortic athlete.
And my name is Ann Herbst. I have an aortic aneurysm in watch and wait, and I am also an aortic athlete.
Hey, Ann, what
Hey,
a
what?
pleasure to have you here this evening as my guest co-host for Aortic Athletes.
Thanks for having me. It was fun being on this YouTube cast a while ago, and I'm so glad to be back.
Well, and Ann, unlike me, you're a professional TV journalist.
I
and
mean, yeah, you
from
can tell by my tie-dye, I'm totally professional.
Yeah, but it's Denver, so that makes sense. And you're at News 9 in Denver, Colorado. You're a veteran TV journalist, and I understand you did a little hike this summer. Is that true?
Yeah, it was a teeny tiny hike that's called the Tour de Mont Blanc, that you hike about 100 miles, uh, circular trek through France, Italy, and Switzerland, kind of circumnavigating Mont Blanc. And it was kind of a really great bucket list type item. I can't really say I do bucket list stuff, but I did that in 13 days with some friends and my husband, and it was pretty rad.
And that's what, 6 or 9 months post aortic aneurysm diagnosis. Is that right?
Yeah, I was diagnosed April Fool's Day, 2025. Isn't that sweet? And I was supposed to get surgery within a month, and then they kind of backed off on that and said, I guess you can go on this hike. And I went on that hike. And I'm grateful that I have physicians who encourage exercise and still encourage my love of hiking in the outdoors in Colorado.
Well, apropos our discussion tonight, and because tonight we have Dr. Patricia Vassalo of Northwestern Medicine in Chicago, who's going to talk to us about arrhythmias, aortic disease, and all things exercise. But before we get to Dr. Vassalo and introduce her, we want you to click like. We want you to go to Facebook and join Aortic Hope and Aortic Athletes group. Remember, our motto is don't quit, adapt.
Yeah, and we wanted to let you know that our mission at Aortic Athletes is to provide peer-to-peer support about aortic disease and exercise, and also to present sound science, including discussions like we're having tonight.
And we also mentioned that tonight's discussion is for educational purposes only. It's really, 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 really important that you talk to your doctor about your diagnosis of aortic disease and your status, as well as the type of exercise that's appropriate for you, because we're all different. And, some people are stable, like I've been for over the last 4 or 5 years. And some of us have our blood pressure under control at 120/80 or less at rest. Some of us have syndromes. Some of us have family histories like me. And that's why you need to check with your doctor about your condition, and don't just rely on a YouTube video, okay? But that said,
So Dr. Patricia Vassalo is a cardiologist at Northwestern Medicine in Chicago. She specializes in cardiology, including women's health. Very cool.
well, and Dr. Vassalo will get you to, if we leave anything else out, but also that you're on the faculty of the Feinberg School of Medicine here in Chicago. And I need to mention one other thing. Dr. Vassalo is my cardiologist. And I'm so grateful, and we're going to talk about this a little later, that she worked with me when I came to her with a really crazy idea about running the New York Marathon post-aortic dissection, 2 years post-dissection in 2023. Well, we'll get into that a little bit later. But Dr. Vassalo, welcome to Aortic Athletes. And, I don't know if there's anything we've left out of your bio you wanted to mention. I know you also do, you're also kind of expert in medicines and in imaging and lots of other things as well.
And yeah, well, first of all, thank you so much for having me. I think this organization is excellent. And I think peer group support is so important on our journey, especially with aortic aneurysms and dissections that are not very common, although they seem much more common these days. And I work with our aortic team, and I think it's really important when you're at a organization that you work with a team. So we have our surgeons, our cardiologists, our radiologists, and our genetic doctors. And so we all work together to make sure that we're doing the best for our patients. Do you want me to jump right in?
Yeah, let's turn it over to you. You've prepared a short presentation on arrhythmias, aortic disease, and exercise, and then Ann and I will ask questions. And then if you're watching this live, you can type your questions as you go along here into the comments section, and Joshua will help us ask those towards the end.
Okay, perfect. So when you think about arrhythmias, there's a lot of different arrhythmias, but tonight we're going to focus in on atrial fibrillation, which is the most common arrhythmia. So what is atrial fibrillation? Atrial fibrillation is a arrhythmia or abnormal heart rhythm that occurs when the top chambers of the heart quiver. So they're basically contracting, or they're moving so rapidly that they're actually not contracting, and they're out of sync with the ventricles or the bottom chambers of the heart. And you can see by the diagram that you can see the normal heart rhythm is regular, and you can see that the bottom rhythm is irregular, and that's atrial fibrillation. There is an association between atrial fibrillation and aortic aneurysm. And what we find is that those patients that have atrial fibrillation have a higher incidence of aortic aneurysms. The converse is true as well. You have those patients with aortic aneurysms are more likely to have atrial fibrillation. Why this is not totally clear, but there's several molecular pathways that are associated with both atrial fibrillation and aortic aneurysms. So one of them is called transforming growth factor beta 1. And what these lead to is very similar in that they lead to inflammation and fibrosis, and they play a role in both aortic aneurysms and atrial fibrillation. So what are the symptoms of AFib? So the symptoms can be, there's a lot of different symptoms, but the most common are palpitations, lightheadedness, feeling faint, and shortness of breath. And it's really important that we treat atrial fibrillation in order to reduce the risk of stroke and heart failure. When we look at atrial fibrillation and thoracic aortic aneurysms, those patients who have both have a higher risk of stroke than the patients that have atrial fibrillation alone. Again, suggesting that there is a similar pathway, but if you have both, it's worse than if you only have atrial fibrillation. When we think about treatment, we want to make sure that we have shared decision-making between the physician and the patient. There are several ways to treat atrial fibrillation, and many times we use multiple different ways to use it. But we start usually with medication. We also can do cardioversion, which is when a patient gets an electrical shock under anesthesia to convert them back to normal rhythm. Patients should see an electrophysiologist, which are my colleagues that specialize in the electrical system, and they can offer procedures like a minimally invasive atrial fibrillation ablation procedure. If you're going for aortic surgery or any kind of open cardiac surgery and you have atrial fibrillation, then you want to consider a maze procedure, which is a surgical ablation or a procedure that gets rid of atrial fibrillation. We did this study here at Northwestern where we looked at patients who were going for an elective open aneurysm surgery, and they had a history of atrial fibrillation. And in those cases, the patients underwent surgical ablation at the time of their surgery. And what it showed was that this is both safe and effective for the treatment of atrial fibrillation. So finally, AFib should be treated to reduce symptoms and reduce the risk of stroke and heart failure. Shared decision-making is important in this process. There's several new technologies that are coming out that are that have come out that are minimally invasive. And if you're going to go for surgery and you have AFib, you should treat the AFib at the same time. And then just a few slides on aneurysms and exercise, because you probably have seen these before. But when we look at aortic aneurysm and weightlifting, we do get concerned about heavy weightlifting. In this study on the left, they looked at 31 patients who underwent a dissection at the time of weightlifting or other strenuous activity. But again, if you look at these numbers, 31, the number on the right is a similar study, but looking at 5 patients. Again, so this data is very limited, but we do feel that with weightlifting, you have a very high increase in or a rapid increase in your blood pressure, which may affect the risk of dissection. But what we also know is that there's new evidence or newer evidence that aortic disease and exercise is safe. And that's true for patients with aneurysms and patients who have had dissection. And Jack can see that one of those studies is his study looking at the impact of peer support. And we know that that's very important for patients with aneurysms and dissections. And what do the guidelines say? Well, there's 2 sets of guidelines, the 2022 ACC-AHA guidelines and the 2024 European Cardiac Surgery Guidelines and the STS guidelines. And the basic tenets are blood pressure control, imaging surveillance, genetic testing, and exercise restrictions. And how they define exercise restrictions is to avoid heavy weightlifting, burst exertion, and collision sports. And both of them basically recommend the same exercise, which is 30 to 60 minutes of mild to moderate intensity exercise 3 to 4 days per week. And you can obviously do more exercise if you want. So those are all the slides I have, and I'm happy to answer any questions.
Well, that's really helpful, and I don't think it's anything that I know it's not. I know that arrhythmias is not something we've covered, and it's not frequently discussed in the aortic community. And I wonder if it's especially important with aortic athletes, because I think I read somewhere that endurance athletes, separate and apart from the aorta, have like a 4 to 5 times greater incidence of AFib than the normal population. So are we aortic athletes like super duper at risk for this?
Yeah, so I think if you're an aortic athlete and you're doing the endurance athletes, like you do marathons, you are at higher risk of atrial fibrillation. And I think that's why it's important, all these wearables that we have, they're really important because they can pick up asymptomatic atrial fibrillation. And a lot of time athletes are asymptomatic because you have high vagal tone, right? So your heart rates are kind of baseline in the 50s. And so when you go into atrial fibrillation, you may only go to 70 or 80 beats per minute, and you may not notice that that's a difference. So I do think that endurance athletes have to be careful about AFib, but not a reason to not do it, just a reason to be aware that that risk is present.
So is that like the Holter monitor,
Yeah,
2-week long thing?
Sorry, yeah, you can do that, but also like an Apple Watch.
Like, this is good enough, doctor. This will tell me enough.
Yeah, because you can't wear that Holter monitor all the time. And so you can definitely do a Holter like every so often with your physician, but the Apple Watch, and now there's more of them that have AFib monitoring, but those are really good to help prevent, if you develop AFib, you catch it right away.
Doctor, do you ever look at that stuff? I know that people hand in some of their outputs from their watches. How much are you looking at that these days?
Yeah, so we look at, we look at it if somebody sends it in to us. But I have had several patients where they've had an arrhythmia, not AFib, but what's called SVT or supraventricular tachycardia. Also from the top chamber of the heart, but it's regular instead of irregular. And I've had people that have told me they've had symptoms for so long, but we can never catch it. And so now that we have these watches, we can catch it. And so if they catch it on the Apple Watch, then they'll upload it to us and then we can decide, what needs to be done. But it's great for AFib too. I mean, we pick up so much AFib that people didn't know about from their Apple Watch.
That's kind of fascinating. I feel better about spending $400 on that then. I didn't have one until I found out I had an aneurysm. So we recently had an aortic athlete tell her story about having an aneurysm discovered as an incidental finding when he tested for tachycardia. Does a correlation exist between these two things?
Yeah, so there's definitely a higher incidence of arrhythmias in patients with aortic aneurysms. And what's interesting is we don't really know why, but again, there's probably pathways that are similar, but some of it probably also is because of the imaging done to evaluate tachycardia. If you get an echocardiogram and you have an aortic aneurysm, the reason you get the echo may be because you've had, fast heart rates or palpitations. And so some of it, and it's kind of the same with AFib. When you have an aneurysm, you're monitored more carefully. So some of it may be that because of the increased monitoring, you're picking up more AFib, but the two are definitely related. And so AFib happens more in people with aneurysms. People with aneurysms have more AFib. So it goes both ways.
I know several aortic athletes who dissected while lifting. And one person I'm thinking of in particular was doing a leg lift, not a massive amount of weight, but enough. And she dissected immediately after the lift. And what I hear from our weightlifters are special people, What I hear from them is my life is over. I can't lift 300 pounds anymore. Between the 300 pounds and the 5-pound bar hand thing, what can they do? How do you calibrate what's doable for our weightlifters? And is it an exercise study? Do they need to come to your office? I know Northwestern does a lot of sports cardiology, and you did a echo treadmill test for me before I did the marathon last time.
Yeah.
How do we know where the sweet spot is for what people can do and not do weightlifting wise?
Yeah, so weightlifting is really tough because we sort of came up with this generic, like, don't lift more than 50 pounds. And we don't really know where that came from. There is like a 1940 work law that said men could not lift over 50 pounds for safety reasons. And some people think it came from that, but it's not really clear. But for a lot of people that lift really heavy weights, 50 pounds is nothing. It's like me lifting 5 pounds. So we try to work with them to see where that sweet spot is, like you said, and see where they're like not struggling or they're not kind of straining. We don't want people straining, but it's usually, I don't like to go over like 100 to 150 pounds with people. But again, I think it has to be very individualized to that person and what risk they're willing to take as well.
Yeah, on the other side of things, our cardiology community is not clothed in glory on this issue, because we get new people who have a minor dilation 4.0 and have been told not to lift more than 7 pounds for the rest of their lives.
7?
7.
Wow.
So no, almost a gallon of water. Like you can still lift a gallon of water.
I would say getting out
How
of
do
my
you go
chair.
through your life?
Getting out of my chair right now, I've lifted more than 7 pounds, I think.
Yeah.
How do we get the word out to the cardiology community about, kind of working with people to get to what's safe and appropriate. Now, if somebody's got a 6.5 aneurysm, maybe they shouldn't lift more than 7 pounds. I don't know.
Right. No, I think that I think the reason we're not better educated is because there's no randomized, like cardiologists like data. They want randomized controlled trials. You're not going to do a randomized controlled trial about you lift 50, you lift 75 pounds. So it becomes this, well, what do the experts say? So I think it has to go to what the guidelines tell us. And again, the guidelines just say no heavy lifting. Well, what is heavy lifting, right? Heavy lifting is different for me than it probably is for you or Anne. You know, we probably have all different capacity for different weights. So I don't know what the best way to do that is, but I know like 4 centimeters, you should have no restrictions. 4 centimeters is like very mildly dilated. So I think, you know, maybe making sure you're at an aortic with an aortic specialist and not just a general cardiologist. I don't know, but I think the guidelines also have to be a little bit more detailed.
That was what I was going to ask you. What Jack and I are talking about are frustrations within the community who have aortic disease. Like there doesn't seem to be like these very specific guidelines. Is that frustrating as a physician to not always just like, yeah, you have high blood pressure, stop eating so much Doritos, but
Right.
but like that's an obvious thing. For this, it seems like it's kind of by the patient. You have to really know your patient, right?
Yeah, I mean, definitely. I mean, if you would have told me that I would have let a patient run a marathon, I mean, I wouldn't have. And probably if Jack didn't advocate for himself and kind of make sure that I knew he was going to like check his blood pressure and that he, you know, his blood pressure was well controlled, his heart rate was well controlled. But I still worried about it because I'm not sure if that was the right thing to do or not. But that's where I think when we talk about shared decision making, that's where that comes in. But I do think if at baseline your blood pressure is well controlled, then you have a lot more leeway when you exercise. But
Well,
I
can I
think
tell?
people are scared. I think that's the big thing. Nobody wants, you know, like you with your aneurysm to have a dissection. So we err on the side of conservative.
Yeah, and it sounds like the doctors, like yourself, a caring doctor like yourself, gets a little bit scared too.
Right. Definitely.
Can we talk about joint decision making then? Maybe this is a good time because when I remember I came I had a visit with you and one of your staff members, and I brought a lot of data. Like I had all my heart rate monitors. This is what my heart rate's like on my runs. My average heart rate when I run, like today I did an 8-mile run, it was probably 105. So you know I'm beta blocked. I'm beta blocked to the max.
Yeah.
I have my governor won't let me get above 125, you know, and my blood pressure afterwards is very low. And I remember you saying, you know, that I remember a staff member saying when I said I wanted to do a marathon, she said, "Why on earth would you want to do that?" You know? And you said, "Well, you know, I'm not going to tell you you absolutely can't, but we will have a discussion about what the risks are and stuff." And and you sent me for an exercise stress test with the echo stress test that Northwestern does. How prevalent should that be for people who maybe are want to push endurance a little bit? Anne goes hiking and she's in the Rockies. She lives in the Rockies every weekend. She's out
Yeah.
in the hills. How important do you think or prevalent should the stress test be?
So I think the stress test is important to see what your, like what you said, what does your heart rate do and what does your blood pressure do? Because some people, their blood pressure is well controlled at baseline, but then they kind of skyrocket when they exercise. And in those cases, we can sometimes push the baseline blood pressure down a little bit. But it also gives you data about what the heart function is doing after exercise. So it gives you a lot of information, both from a hemodynamics standpoint or like the blood pressure, heart rate, and then also what is your functional capacity? So like, are you able to exercise pretty far? And so like for you, I know you can exercise far, but we wanted to make sure that your blood pressure was controlled. For other people, I might do it to make sure that their heart function is normal after they exercise. So there's a lot of good reasons for stress tests. But I don't think everybody needs a stress test.
Well, who does, that's interesting because just personally, my care team says they don't think that I need a stress test. So how do you make that decision? And are there any other tests you recommend to people?
Yeah. So I don't do stress tests like routinely. And I think in Jack, the reason I did it was because I wanted to see what his response was with exercise. Now, he told me what it was, but when you do a stress test, you have it real time, like you're getting it right as they're in stage 1, stage 2. So for someone with just an aneurysm, I don't usually get a stress test. But I think the reasons you do stress tests are if you think someone has a blockage in the artery, that's the main reason. So chest pain, shortness of breath when they exercise. But in Jack's case, I did it to see what his blood pressure response was to exercise.
And we
And
have
you're
some,
also doing your exercise, your hiking is like a stress test in a way because you're exercising, so vigorously. So that's probably why they don't think you need one.
Are there
So I
any
think-
other tests that you recommend? Is that kind of it? That's like the one, the guy?
Yeah, no, I mean, with aneurysms, I would, obviously, you're going to follow it with either an MR angiogram or a CT angiogram. And then I always get an echo in anybody with an aneurysm, just to make sure that they have a trileaflet or, see what their aortic valve looks like. But stress tests are not like usual in an aneurysm. It's not something I usually get.
when we did our survey of aortic athletes, about half are in watch and wait, like Ann are, and about 36% are post-dissection, and about 17% are post-repair, no dissection. And I think Dr. Braverman did a study in 2022 of endurance athletes post-repair, no dissection, no syndrome, no family history. And, the results were pretty good. So I think there were 300 people, 30 people had done, I don't know, 100 or 200 or 300 endurance events with no bad things. So, so there's at least beginning to be a little bit of data.
Yeah, no, I think this is an area of real growth and people are really interested in it because the patients that are having dissection, have such better mortality rates than they used to. So we have so many people, if you just look at Northwestern, I'm taking care of so many patients who have had their dissection and they're doing great. So they want to know, what can I do? And they don't want to live a life, where they don't exercise, and they shouldn't, because it's healthy to exercise. So I hope that we keep having more data for us.
And just go back real quick to the arrhythmia issue and an ablation. So is an ablation a big deal? Is it like, I mean, I've had open heart surgery twice. Is it, how does it compare? Is it something, is it just a day in the office? Is it, and how effective is it?
Yeah, you usually stay overnight, one night, but it's all through the catheter. But because so the atria, what you do is the pulmonary veins enter the atria, and it's near the pulmonary veins that you start to get this chaotic behavior. And so that's what you ablate. And there's different ways to do ablation. Like you can do heat, you can do freezing, you can do this like high pulse electrical energy, but you're basically like kind of killing little cells that are transmitting this chaotic process. It's very effective, but it's not 100%. We usually quote people like 75 to 80%. It is done on the left side of the heart. So they basically go in through the vein on the right side and they make a little hole through the interatrial septum. And then they get to the left side, and then that's where they use the catheter to kind of destroy that a little bit of tissue to prevent that atrial fibrillation. So it's not open heart surgery at all. It's usually one night in the hospital. The major complications are bleeding, and sometimes they can poke a little hole in the heart that causes fluid to get around the heart and they have to drain it. And then stroke is another complication because you're on the left side of the heart. But again, they're, very low risk of those serious complications. And pretty effective.
Yeah, I've known a few people who have gotten those and said it like they wished they would have done it earlier and been able to do it earlier. One including my brother, who used to go and roll in snow to make his heart go normal heart rate.
Oh my God.
So it sounds like I mean, it's been life-changing for a few people that I know who've had that.
Yeah, we used to have to try medicine before you did an ablation, but now you can go straight to ablation. And that's what I usually recommend for my patients.
Excellent. Jack, do we have an audience question?
Yeah, but before we do that, I have a question that was sent us from aortic athlete John Groves. And Dr. Vassalo, our favorite drug to complain about are beta blockers amongst aortic athletes. And some folks are wondering, how do I get off it as soon as possible? Why do I really need to take this drug? And John says, for people who are in watch and wait like him, the guidelines call for beta blockers and ACE inhibitors like losartan. And should there be more debate amongst those writing the guidelines, I think he says diplomatically, about ACE inhibitors as opposed to beta blockers? What's the state of the science right now on one or the other or both? And does anyone with aortic disease ever get off the meds?
Yeah, so that's a great question. So the only people for me that I don't have on beta blockers are people that already have a very slow heart rate at baseline. Yeah. Anne's pointing to herself.
45.
Yeah,
You could
so
not put me in a beta blocker, I'd pass out.
That's
Right.
normal, Ann.
Yeah, so usually if they're like in the 50s, I won't, or lower, I won't start a beta blocker, but beta blocker really are the mainstay of treatment. But there are some patients that, just can't tolerate them, and I have them on losartan only and not with a beta blocker. But I would argue that beta blockers are really good for the heart, good for the aorta. And that, but if you have a lot of side effects, sometimes people have to stop them. But the data, I mean, as of now, says that beta blockers are still the first line treatment.
And is that particularly so for those of us who've dissected? I mean, I know of like one. I think I know of one aortic athlete who's dissected. She's actually also the only person to do an Ironman after a dissection. Where she needs to be studied. But she has an incredibly low heart rate without the meds, and I don't think she's on beta blockers. But all the other folks I know with dissection are. I think that's pretty much the norm, isn't it?
Yeah. Beta blockers are the first line treatment. And so we start them as soon as they're, when they're off, if they're on pressors or the medicines that keep their heart rate up after surgery, as soon as they're off them and stable, we start beta blockers. So I don't know if I have any dissection patient that's not on a beta blocker. And you said how long? It's your life. You don't go off of them.
Never, ever.
Never, ever. If you want to keep doing well, you stay on them.
Yeah, and that's tough medicine. But what I found was that after 2 years, my body adjusted for some reason. I had the fatigue and everything for a long time, and something kicked in, and now I really don't notice them too much. Joshua, are there any questions from our wonderful live audience?
We do. We had an early question come in. First off, hi Terry, and hi Chris. Chris asks, similar question regarding exercise intensity. Is there a general guide or correlation between a moderate heart rate exertion level to minimize risk of spiking or elevating blood pressure?
Say that again, Joshua.
For sure. Is there a general guide or correlation between a moderate heart rate exertion level to minimize risks of spiking or elevating blood pressure?
Yeah, I think one of the keys about like spiking blood pressure is to try not to do, like, example would be like high intensity interval training where you go really fast for brief kind of bursts of exercise, and to do more gradual. Now, if the question is, is your heart rate going to tell you your blood pressure? Not necessarily, because your heart rate can go up faster than your blood pressure goes up. But that's where I have people get a little bit creative and sort of have a blood pressure cuff there and do their exercise and then check your blood pressure as fast as possible. It's not exact, but it can give you a guide to see what's happening. But most people, if I have their baseline blood pressure, under 120/80, then what they do with exercise is usually they won't go, too high with exercise.
Exercise with moderation.
When we did the
Yeah, moderate.
Dr. Siddharth Prakash did the post-aortic dissection exercise study. I think it's still going to be published. There's about 100 people. And they actually took our blood pressure while we were doing bicep curls. So you're bicep curling on the left and taking blood pressure on the right, and or doing a wall sit or a couple other things to see if you were, I think people were disqualified if they were over 160 during the exercise. So great question. By the way, how do we know what moderate exercise is? So is there a rule of thumb if I'm out on a run? What would you say?
Yeah, it's hard to exactly quantify what moderate, but we think of like jogging as moderate, whereas like if you're like kind of speeding like faster than jogging, it's probably more high intensity. And then you have the endurance where it's just the duration is longer. But we think of moderate as jogging, elliptical, stationary bike. But there's different ways you can do that, right? You can ride a bike super fast. So I usually tell people when they exercise that they can to like use their breathing more than their heart rate, because they might not want to always be checking their heart rate. So if you're like breathing and you're absolutely not able to talk to anyone, then that's really high intensity and you should probably pull back if you want to be in that more moderate intensity.
As a physician, does it make you excited to hear that there's actually some studies going on finally with exercise in this? Because I'm guessing it's very challenging. I often ask my cardiologist questions. She's like, I'm going to go check with someone else. Is it exciting to see some of this research going on with this disease that seems like more young people, like they're finding it in more young people like myself, because of increased scans and tests and whatnot? What's that like for you to see?
Well, I mean, just being here tonight and all of the camaraderie you all have, but also like the individual experiences. And then now with more data coming out, I think it's very exciting because this is what I do. And this is what I love, to take care of patients that have had an aortic dissection, and they want to know what they can do. And the whole thing is they just want to be back to what they were doing before. And most of the time we can get them back to what they were doing before. We just have to make sure, again, their blood pressure is, well controlled, that they're beta blocked so their heart rate doesn't go too fast when they're exercising. But I think that the more patients that we have that are younger, that are surviving, then there's going to be more studies, because there's going to be more people that want to know.
Joshua, are there other questions from the field?
Chat is quiet.
Okay. So in one of the findings from our survey of aortic athletes is that 70% of people are afraid to exercise. Did that surprise you? Did it?
All right, no. Because I think like Anne, I think it was Anne was saying, or maybe it was Jack, but your doctor doesn't even want you to exercise, right? 7 pounds. I mean, what is 7 pounds? So if your doctor doesn't want you to do any exercise, then why would you do exercise? And what we find is that people that don't exercise do poorly no matter what, what happens. And so I think that we do, as cardiologists, need to be better educated that patients can exercise and they can exercise safely. But if you look at the data, it's mostly retrospective, numbers like 50, 100. I mean, these are not big numbers. And so I think we just have to keep trying to make sure that we're doing more research in this area. It's a hard area to do research in, but we need to do a better job.
Yeah, I think in general, the survey showed that most people are hearing like no Valsalva maneuver, no grunting, when lifting, and no, trying not to spike blood pressure. But then I think 20 or 25% of the survey folks, they couldn't recall their doctor saying anything about exercise. So it's like it wasn't even on the list of things to go over.
Yeah. Yeah. And I mean, I think sometimes there's just a lot going on in that first visit with someone, but like that should be top of like what they can do. Especially, you do want to make sure that people aren't lifting really heavy weights, especially like weightlifters, like those people that lift 300 pounds, like they really can't lift 300 pounds anymore. They have to bring the weight down. But I think, again, patients or doctors sometimes don't know what to tell patients. And even when we tell patients, they still have specific questions like, can I do this? Can I do that? Can I do that? And so it's often hard to, answer all their questions. And that's why things like this, where people have like a peer support group, I think are really helpful.
And what role does stability play? So, Anne's been diagnosed since April Fool's Day. I've been diagnosed for 5 years. Obviously we want people to be stable, and some folks get a diagnosis and the aneurysm is very large and they're going right into surgery. But how does stability play into the volume or extent of exercise?
Yeah, so I think if you're like, obviously, if you've just had a dissection and you haven't had any scans after your first one, we're going to be much more restrictive on your exercise than if we have like 2 scans in a row that look stable. With an aneurysm, it's sort of the same thing. If you start seeing the aneurysm like growing, you'd still be able to do cardio, you'd still be able to do like elliptical, ride a bike, a stationary bike, do jogging, but I think that you just make sure that they're not doing anything that could be causing the progression of their aortic dilation. But I would say that when people aren't stable, we restrict their exercise more.
And then, do you have any tricks to get people who are basically sedentary to start exercising? What do you have any suggestions? Because aortic athletes, I think we have a lot of lurkers. Like, I think we have a lot of people who want to be exercising, and they think, well, if I read about it, that's kind of like exercising.
Yeah.
How do you motivate people?
I mean, I just try to get them to understand how cardiovascular health is improved by exercise, and that it also improves your mental health. It improves stress. And so what I usually will tell people is just to start with just a walk, go even for like 10 or 15 minutes and try to build on that. But it's kind of like when people quit smoking, they do need to be motivated, but they also need to be encouraged. And so I think just each time you see the patient, just trying to, do motivational interviewing with them in order to kind of see where they're at and what they could actually put into their day. But I feel like most of my patients do exercise. I mean, like I can get them to be less sedentary. But it's just walking. Like walking is something where
That's
most
fine.
people can do.
Yeah, it's good for the brain too, right?
Oh, absolutely. Yeah.
Because that's
for
half
our
the battle
stress.
with this one, right?
Yeah. Oh yeah, I think for people like Anne, like you're living with this aneurysm, I think that's a really tough thing. And one thing when I tell my patients, like when they first get diagnosed, I said, it's going to get easier because you're going to be like, here's my yearly scan. This is what I do. Like, it's more routine. But for the beginning, it's hard to live with that. And that's why when people are able to still exercise, I think that's really helpful.
Keeping a sense of normalcy or creating a rhythm of normalcy, I guess.
Yep.
We've had several aortic athletes who've had open heart surgery in the last month or so, and they put pictures of their scars, and they you know, as they're coming out of the hospital after a week or so, and all of them have mentioned how not training for open heart surgery, but how being fit going into the open heart surgery made the recovery easier. Is that a true thing? Is that a real thing out there?
Yeah, no, that's absolutely true. I always tell my patients, remember after surgery, well, you remember this, but like you can't use your arms, so you got to use your belly. So we actually can sometimes, it's not done everywhere, but it's called like pre-physical therapy. Like before you go in, they work on the things that you're going to need to do during surgery. Now, aortic athletes are different because they're, you know, athletes, so they're going to be able to use their stomach. But like for our older patients, we try to practice with them before the surgery. So it definitely helps if you're because people will say, I don't want to have surgery. You don't want to have surgery, but if you have to have surgery, you want to go in as fit as possible because that will absolutely help your recovery. So if you need surgery, you'll be good to go. with
I'm
all your
going to,
height- with all
I've been
your height
told
change.
I'm going to need surgery, but we'll
And
see.
what's the highest mountain you've climbed in Colorado this year?
I've only gone to 13,000 this year. I didn't do any 14,000 because the cardiologist was like sort of on the fence about that, but told me I could go to 13. There's really not that much of a difference. But I think like finding a doctor like you or the doctors that I have who are very encouraging of exercise instead of saying you can only lift a small cat is very helpful. And it's probably encouraging for you as a doctor too, to hear that there are doctors elsewhere. Has there been anything in the past few years that has made you really encouraged about this disease? Because they used to say no exercise at all.
Yeah.
Has there been anything that you've been like, this is good, we're moving in the right direction?
Yeah, well, I think that the awareness, and like you said, the imaging. So, someone comes into the ER now, they almost always get a CT scan to look for a pulmonary embolus, and then we pick up a dissection. So, I think it's awareness, and I think it's the imaging. But I think what we're learning just about surveillance and making sure that people don't if you have your dissection, you can't just go away and you're healed. No, you got to every year, you got to come in for your imaging, or it can get spread out as you're stable. But I think just the way people are surviving after these surgeries is amazing. And I think, again, what you guys are doing, what Jack did, like running a marathon after a dissection, I mean, that's impressive. And that makes me hopeful that we'll keep moving in the right direction.
Well, to be fair, it was 6 hours and I jogged.
That's good.
Well, Dr. Vassalo, this has been an absolute pleasure. We are, I always say that aortic athletes, we do the peer-to-peer support like that we can do, that we're really good at, but we are an empty gong without people like you willing to share your expertise with us, because we don't know it. And we're very, very grateful to you for speaking to us tonight, and for kind of, adopting our community and being a friend of aortic athletes.
No, well, thank you so much. I really think what you are all doing is excellent.
Thank you so much for being a female cardiologist. Rock on, sister.
Rock on.
But what is it, like 15% of cardiologists are women, and Jack has one and I have one.
Oh, see that?
And you are the
Women
first.
doctors are the best.
You are the first woman cardiologist we've interviewed, I'm ashamed to say. But
yeah.
happy. I think I hope you're the first of many, many more.
Yeah. All right. Well, thank you so much. I really appreciate it.
Okay, thank you guys. Thanks and good night, everyone.
Thank you so much.